Hi, good morning, everyone. My name is Caroline Zananek. Happy to have you guys here. I am part of the committee that is bringing you this wonderful session today on a CPT booster. So I want to introduce you to our other facilitators today. We have Brett McCone, who is the Senior Vice President of Healthcare Payment for the Maryland Hospital Association. We'll have Sheldon Pink, Vice President of Revenue Cycle for Luminous Health, Lauren Shea, Managing Director of Kohler Healthcare Consulting, as well as myself, Caroline Zananek. I'm a Managing Director with Cone Resnick. So just to give you guys a bit of a background on today's event. So this had started a few years ago as a one-day in-person event to discuss January 1st coding updates, all of the different challenges associated with them, and any other hot topics that may be coming into regulation or things that have been changing along the way. So it was meant to be a very interactive type session when we all got together, and it was great. And then of course, COVID came along. And what happened with COVID is it became now, and it has evolved into a two-part series as part of the Region 4 webinar. There was one that on the coding updates that was held earlier, November 16th, and then our deeper dive for our Maryland chapter members into the updates and other topics. And that's what's bringing us together for today's event. So after we go through the agenda, we are going to have breakout rooms for more in-depth discussions with your peers, and those are going to be broken down by the EHRs you may have identified with during your registration. So what you'll see is after we go through the agenda and some discussion with our facilitators is a pop-up window that's going to ask you to accept your room assignment. So please do that. And Lauren will give you a little bit of a reminder as well as we get closer to that time. So as a reminder, meeting attendees, you are in listen-only mode and view-only mode. You will not be able to share your screen or speak. This event is meant to be interactive, so the chat function is highly encouraged and you have access to that, and it will be monitored throughout. Keep in mind that today's event is to focus more on operational topics and tips for implementation. If you do have a technical question, certainly feel free to put that in, but we may not have time or be able to address those today, but we can take them outside of the event and look forward to getting back to you. And then a final note before we get started, you are eligible for AAPC CEUs as well as HFMA CPEs for this event. You'll want to contact me directly for those, and I will send that back. So you have in the handout my email. If for some reason you can't find that later or you don't have the handouts, you can find me. Probably the easiest way is to ping me on LinkedIn because our emails are very long and my name is not the easiest one to keep up with and spell. So I get that. So as we go forward, I'm going to go ahead and open up the discussion now. We are getting into our topic with Lauren and Brett, or starting with Brett on our MHA topics.
Okay.
Brett.
Thank you, Caroline, and good morning, everyone. Appreciate everybody joining us this morning. Been, of course, a long time pleasure to serve all of you with HFMA, and always enjoy the opportunity to get back in front of everyone and to talk about all kinds of fun things like what's going on in MHA, and everybody's favorite topic that we've included under this general heading of consumer cost exposure and the recent regulatory actions around this. So when we were putting this together, Lauren asked me to speak about, well, what are you doing? What's new at MHA? What's the MHA perspective on things? So given our, the other topics today, I'm going to focus on these things. Before I do that, though, I did want to, make sure everybody is aware. I'm sure everybody is at this point. On Wednesday, we did submit a letter to the HSCRC asking for a January 1 hospital rate adjustment of 0.65%. So if we're going big picture strategy, Lauren said, well, what's the latest from MHA? Well, the latest from MHA is when we look at the labor market consequences, when we look at inflation, when we look at our staffing challenges at hospitals, we've gone to the commission and said, you need to raise hospital rates at this point. So they have that, and they will, be looking at that likely over the next month to make a decision at the January 1 public meeting. That is, first and foremost has been top of mind for, for folks from a rates and revenue perspective. So back to the topic at hand that is just quite as exciting as the whole overall rate increase would be, consumer cost exposure regulatory actions. So a couple big focus areas, what are we focused on right now? One is addressing the facility fee regulations. And the second piece is addressing the, HSCRC payment plan requirements. And that affects hospital debt collection practices beginning January 1st. So on the first topic of facility fee regulations, and judging from those in the audience, I know many of you are intimately familiar with this issue. The commission, the law was passed. We had hoped that there would be at least a 6-month delay to January 1st. Ultimately, that didn't happen for a variety of other political reasons. So law took effect. HSCRC has regulations that they released after discussing it publicly at the September meeting, though those regulations have not been formally published in the Maryland Register. So the formal comment period on those regulations isn't open yet. But the commission did publish those regulations in their post-meeting packet. A few things we've heard from you and a few things that we're working on. Number one, there's been a concern about Medicaid patients and the disclosure to Medicaid patients. And we're hearing from many of you just what the operational impact has been when people are suddenly getting wide-ranging estimates, and that is causing people to cancel appointments, to really get upset, to postpone necessary healthcare services, particularly with the Medicaid population where there is no cost sharing, and that's what the original intent of this bill was. So that's one of the things that we are plan to work to address. The second thing in the commission's in looking at their regulations. There's a whole question about whether or not a signature is required, and then what that means from a commission standpoint if you don't receive a signature that the patient acknowledged that you disclose the facility fee, to the patient. And as we think about this, we understand that provision, the regulations that the commission drafted talk about the hospital shall make its best and reasonable efforts to obtain the written acknowledgement. And they go on to sort of conflate that about providing, whether or not you provide the service. Our point is this, that if the hospitals have discharged their duty to disclose the fee, we believe that when we look at this, our position would be that meets the spirit and the intent of the requirement. Whether or not the physician acknowledges, the patient acknowledges it is a different conversation. But as long as the hospital can document that they, that they discharge their duty, that will be our position. As the commission works through that, that'll be the piece. The other thing that was new in that regulation is that the commission wrote it specifically to say you need to disclose at time of scheduling, which we all agreed, and then disclose again at time of appointment. And we don't think that that second disclosure, at the time of the appointment should necessarily apply, mainly because when you go read the law, it's not in the law. So this is, another one of those sort of operational things we're working at. At any rate, the takeaway from this is we're on this. We have heard from many of you. We have worked with many of you. We know this has been an issue, a tireless issue over the last several years. And we need to gather the experiences and the stories from all of you, because as we talk about, at a big picture level from a legislative perspective, talking with the commission, talking with the Attorney General's office to say, here was the intent, like we understand this. Let's tell you what's happening on the ground. And here are some of the things that this is causing. And, can we think about, what would improve this? Whether or not, we get there, those are the types of things that we need to think about the experiences, and really viewing this through a consumer's, through the patient's lens, as to what makes the most sense to them. So that's the topic on facility fees. The second one is then the HSCRC is attempting to finalize their payment plan guidelines that should affect hospital debt collection actions beginning January 1st. If I woke up this morning, it is now Friday, December 3rd. I do not expect those guidelines will be published or complete by the end of December, nor, as many of you know, that there is a requirement to go to the board to get approval for financial assistance and debt collection policies. So to the extent that hospitals update their policies to reflect these payment plan guidelines, what does that mean? So our point is we are trying to work with the commission as quickly as possible. At the same time, we are trying to work with them to get clarity on what this means if payment plan guidelines are not established effective January 1st. If you read the law, the plain letter of the law says, when the law takes effect, hospitals shall not be able to pursue legal action on outstanding claims until such time as the commission establishes payment plan guidelines, and the hospital's guidelines are in line with those payment plan actions are in line with the commission guidelines. So what's interesting is to say, okay, commission, well, if you haven't published those guidelines by January 1st, we want to get an opinion on what that means, for the state, whether there's any wiggle room because you haven't published the guidelines, or does the law stand as written that says we cannot pursue these types of collection actions until you do that. So we're working as expeditiously as we can. I think the commission, they were working on hiring a contractor to assist them with writing those guidelines, with those that have more experience around hospital payment plans and what that looks like. I think there is general sentiment that we want to maintain as much flexibility as we can with those payment plan guidelines, but to make sure at least there's some structure around them. And my hope is that the commission will be flexible around the guidelines, but that if we need more structure around them and more consistency, that may be something that they establish. And that's been an ongoing question from folks that play in this area. The last piece, pulling up from some of these operational impacts right now, is the whole need to address consumer cost sharing under global budgets. So, this will be a topic as we're thinking about the future, the big picture future of Maryland's model agreement with CMS and CMMI. And so we, of course, in Maryland have the ultimate incentive of fixed revenue to reduce as much avoidable utilization as we possibly can. And this has been largely successful in the first 7 years, where when you look at our hospital utilization change compared to the nation, we have controlled utilization much greater than the nation has over the last 7 years. Of course, the trade-off with that is to maintain fixed revenue at lower volumes is to raise prices to hit your GBR cap. Again, this is not a secret. This is how the mechanics work. And of course, the benefit to that is the growth rate over time is lower. But when we think about that growth in prices as volumes have fallen and hospitals have raised prices to achieve their GBR, several folks have questioned, okay, well, what does that mean from a consumer cost sharing perspective? And is that something that we can potentially mitigate as volumes fall? So this is a very big sort of strategic conversation because there's lots of simple answers, but the answers are more complex. Of course, the payers, and the health plans establish cost sharing as a way to incentivize folks to use services effectively, and that's absolutely a fair and appropriate way to incentivize the use of services. So as we think about that, we need to understand, okay, well, what would become the patient's responsibility? Would you change that at all to say, this is the commercial insurer's responsibility? At the same time, there's a whole discussion under global budgets about whether or not it should be like an interim payment, and there should be a settle up, later. And do you just have, okay, you draw it on a monthly basis and we settle it at the end of the year, and that fixes the cost sharing problem. Other more radical ideas are, if you look at Vermont, their system for Medicaid beneficiaries, the hospital gets a check from Medicaid. And it's essentially like a block grant that says, here are your, here's your payment for your Medicaid beneficiaries. And that allows the hospital to do whatever they think is in the best action with the ultimate freedom and flexibility to be able to, use their funding as they see fit. So if that means, clinics, if that means doctors, what have you. But again, it comes back to this mechanical issue about, cost sharing under global budgets. I'd expand that just a little bit, and then I'll stop and happy to if we're doing questions, happy to take questions. As we think about, future changes and the service, the model agreement and what this means, it could go beyond global budget cost sharing, because we think under global budgets, here's a great example. Under global budgets in Maryland, doesn't matter whether the patient's an inpatient or an observation patient. I know all of the revenue cycle compliance people just lost their mind when I said that. But from a revenue perspective, right? Like, does it really matter under global budgets? I mean, think about how much of, the administrative stuff that we create that's been a function of payment structure, right? Well, we created, observation, and we created, all of the inpatient rules because, well, health plans thought inpatient was too expensive. So we're going to require these things to be outpatient, and we're going to move the business to outpatient. Well, if there's really no incentive or no pricing difference, does that really matter? And are these the types of things, can we get out of this box and think strategically to take away some of this operational burden? I know some of this is radical. Now, I just think I overwrote like federal law and the Social Security Act with that comment about, what's paid, what's an entitlement under this section versus what's an entitlement under this section. But, these are the types of things as we, think about to say, if and I would challenge everybody here too. My homework assignment is, think about the 2 or 3 big things that, we get bogged down in and we talk about, and we have all kinds of, front end, middle, or back end revenue cycle process where we're thinking about this in the context of, trying to do this for health plan requirements or Medicare requirements, and why that would be different here in Maryland because of our incentive structure. So with that, I just get so charged up about talking about these operational impacts. I could go on all day. Let me stop there. Caroline or Lauren, please tell me what to do, whether we're taking questions or we're moving on. Happy to do whatever we need to.
We're happy to take some questions. We have some time in our agenda. So if anyone has any questions for Brett, if you want to put that into the chat box, we can certainly do that. And I think, Brett, thank you for sharing definitely this update. You guys do a great job of keeping the membership up to date and on track. I think we also, here's a disclaimer, right? As these are our opinions and not necessarily those of the companies or organizations, right? We represent. So I love your crystal ball and your intuition as far as what you're thinking of too, of what can make things better, because I would love to rewrite federal law myself and have it come back to the states in a more consumer friendly way.
What do folks think? What questions can we try and answer? I mean, I'm happy to go on, longer about other things that MHA is working on, outside of these particular pieces. But happy to answer any questions. If you put them in the chat, I'll try and answer them as best I can.
But it doesn't look like we have anything yet. If you have anything, if we can move forward, or if you have something else you want to share. I think we were slated to start our next item about 8 minutes from now, so
Okay.
we can
I
give you
can share
that
a couple
floor.
other topics. I mean, so a couple things that we've got going on from a broader MHA perspective, right? As we look forward, it's December 3rd. The legislative session will start in January. So, we will see this. This will be an election year coming up. So you'll see lots of different, things going on in the legislature. Couple things from an MHA perspective. We are focused on workforce issues and what we can do to improve the workforce pipeline, to our hospitals. That's no secret. As we talk with many of our chief financial officers and our chief executive officers, just about the labor challenges to staff, the hospitals and to staff the units and what that is doing to strain finances. So, that's a big focus of ours is, what can we do and anything that we can do to improve and, have a robust workforce is on the top of our list. The liability climate here in Maryland, remains a challenge. So, we are continually focused on that. Raise your hand if you're a trial lawyer. So, we have a continued focus on that issue to have, what is a very, very, very challenging climate for medical liability here in Maryland. We're continuing to focus on that. The other things, again, we've seen, these past things with the consumer cost exposure, and we've been working with, various folks in Annapolis to understand their perspectives and to, as we think about those, to say, are there solutions that are not legislated solutions, or are there other opportunities, that we have to address concerns before we do that. That's probably, from a legislative perspective, that's coming up over the hill. That's, sort of an immediate need. The other thing from a very, very, very strategic need perspective at the commit or at the association right now is that by the end of 2023, Maryland, the state of Maryland, has to come to an agreement with CMS on what the new savings target should be, the savings target measures in our contract agreement after 2024, beginning in 2024. So if we want to talk about, the real big overarching, strategic vision of things, this is one of those things that we have to look over the horizon, because we are now in the second phase of a two-part demonstration project that began in 2014. The first one ran 2014 to 2018. We're in the second phase that runs 2019 through 2023. And once we've completed this second phase, then we have the opportunity to work with CMMI to say, can we agree on a longer term model extension? And what would that look like? So, as we think about that, beginning in, we have to save $300 million on a variable growth rate versus Medicare by 2023. And we're on target to do that. COVID's been a little fuzzy about what that means. But when we get beyond that, beginning in 2024, then, what can we do to ensure here's a fair target at some point out in the future, but one that gives us long-term stability. So we know what that target is. And once we achieve that target, that we would have no more savings that we would have to give to the federal government, right? Because we know Medicare pays higher here in Maryland. And if we kept giving savings, off that growth rate to Medicare in perpetuity, at some point, during the future when we're all replaced by robots, those lines would cross and we would actually give Medicare more savings than we would have value as a waiver. So at some point, we've got to find that plateau to say, okay, here's where we are. I give you the long-winded setup to say, MHA, our hospital executives, the commission have been actively working on this. And we are working to, first to discuss with the hospital field and with HSCRC, what is a reasonable target? What are reasonable parameters to address that? And then the second would be, what's going to be the state position? And that'll be working with the HSCRC. That'll be working with Health Secretary Schrader to take this, to present this to the Center for Medicare and Medicaid Innovation, and then in 2022, because they have to go through a very long process. But if you want to talk about the real big high level strategy of what ultimately governs how much we get paid, what the commission allows to come into rates, and we factor then all of these other sort of payment level things underneath of that, this is a big deal. If you want to read more of that, the commission, their modernization page on their website has the old contract, or has the current contract that we're under. I encourage folks to read that because I think it outlines, the other things we need. Last piece I'll say about this, and I want to stop again, is that the CMS and CMMI want to see Maryland invest in population health and transform care. What they have said point blank to the state in the past is, look, if we wanted Medicare savings, we could just put you guys on PPS and be done with it. And that would be the easy button there. But they don't want that, right? If that system works so well, they wouldn't need a CMM, they wouldn't need an innovation center to come up and change, to change payments. So, they really want to see us, how do we get further upstream the things that we're doing to, really reduce downstream spending costs. It's a unique challenge. They're really focused on that. So, when we look at, population health type measures or other, big, wide quality measures, they're going to focus on that as well as part of this agreement. So, Caroline, back to you again. Happy to answer questions here for a minute or two. Went real high level on those things, and happy to go deep on, any specific topics, or happy to go high level on strategy.
We don't have any additional questions in the chat box. So Brett, I'm going to go ahead and move on to our next topic, but certainly, if you can stay on, if you want to provide any, Sheldon and I will be talking next on the No Surprises Act. You touched greatly on the facility fee disclosures. We probably won't touch much about that. And then also on the price transparency piece. So happy to have you jump in from the MHA perspective as we go through these topics. So I'm going to kick us off on this section of our session today. So when we talk about the No Surprises Act, for many of you, hopefully by this point, you're at least aware of what it is. We've gotten through the surprise phase of the act itself coming out, but understanding that this is an interim final rule at the federal level, which basically means it's a moving target. It's one of those rules that comes into place and it comes in different phases, and they may push out rulings and items that are effective, but pull back enforcement or ask for comments from the public, but still at a momentum moving forward, that the expectation isn't going to change, but they're looking for public comments on the implementation of some of those expectations. So without getting I know we talked about not getting too far into the detail of the technical pieces, but I feel like there's some items that are hanging out there when we talk about the NSA as far as common myths. And then I'm going to bring in Sheldon to talk through and share just some of the things that he's been seeing and what they've been doing as far as addressing the NSA overall, and then also price transparency. So the NSA itself, if you look at the interim final rules, it's in multiple parts. The first part came out, and that's really where a lot of people had a lot of lack of ease related to it, because it was hitting a lot of different stakeholders. You had the patient involved, you had the providers, the facilities, as well as the payers and the plans. A lot of different people. So that's a lot of different stakeholders to try to coordinate, and especially in a prescribed type process as it relates to any type of estimates, transparency and cost sharing, obligations to what can and cannot be paid. And then as we get into out of network type benefits, more so for those services that, for example, may be in a freestanding emergency room or an urgent care center, that type of thing, is really understanding how payment is going to be made for out of network type patients. So how I'm going to split it up real quick. What's happening January 1st, and one of the first things that you need to realize is some of what is going in, especially on our Maryland hospitals, isn't as scary as it might be for out of Maryland hospitals. Primarily when we talk about a patient coming in to the emergency room that's out of network and waiting for the payer to come back to say what they're going to pay. because of our all payer model, that's pretty much already prescribed of what's going to happen. And then, it's more so in the cost sharing piece for the patient as far as what their financial obligation is going to be, and to what Brett spoke to, understanding what limitations we may have there. So when we talk about all service locations are included, the NSA in the Part 1 talks about good faith estimates, advanced EOB, some of this might be familiar to you guys, disclosure and consent. That was for hospitals, hospital outpatient departments, emergency rooms, ambulatory surgery centers, freestanding emergency, and then any urgent care clinic, or it could be chain, that is licensed by the state to provide emergency services. So what you don't hear in there is your privately owned physician practices, your freestanding diagnostics, your freestanding rehab type centers. That's not included in that piece. Where they did get included was in Part 2, talking about the uninsured population and providing a good faith estimate. That is now open to all and any healthcare licensed providers and facilities. That's where that exclusion is, and some people have lost that. So when we talk about all service locations, it really now gets down to, are they insured or are they truly uninsured self-pay on what locations are going to be included and what is included. So good faith estimates are not going to be enforced and required for your insured population, whether in network or out of network, starting January 1st. The enforcement date of that has not been announced. They're looking for comment period. They're having a comment period, looking for some feedback related to when that would happen. What is going to be enforceable is going to be the good faith estimate for your self-pay uninsured patients. And these are for, when we talk about the estimates for all services, these are for scheduled elective type things. These are, you think about in the world of price transparency, what's shoppable, what they can actually call around and shop for. That is going to go into effect at that requirement for January 1st. Now, what's not necessarily going to be enforced, and I know a lot of people are getting a little bit of heartburn on this one, is what do I include? Because if you look at the interim final rule in that Part 2, it talks about different terms between a convening provider, a convening hospital facility, however you want to put it in there, and then they have the co-provider, co-facility piece of it. So your convening provider, that's the person that you're first going to and saying, I want this service. So that could be a surgeon, that could be your primary care doctor. And then in providing care, is the co-providers and co-facilities. The expectation as it's written was that the convening provider would gather even the co-provider and the co-facilities information related to their expected charges for the purposes of providing that good faith estimate to the patient. If you go through the interim final rule, it's a lot of reading, but you finally get to the point towards the end where HHS comes back and says, we realize that's probably not going to be easy. So they're applying enforcement actions to be discretionary at this point. They expect, at least as the convening provider, that you have access to what your charges are and you can provide the good faith estimate, but realize that you may not be able to pull together the co-provider or co-facility information. And they're giving a time period related to that for providers that work together and facilities to figure out how to ultimately come to that overall estimate. But again, there's going to be discretionary enforcement prior to that. So we have some breathing room. Hopefully that gives you guys a little bit more of ease here too. On the price transparency piece, just real quick, fines are increasing beginning January 1st based on your level of noncompliance and the facility number of beds. They're basing it based on beds. So the fine itself is going up from a cap of $109,000 and some change to over, I believe, $2 million. So some tips for avoiding a warning letter and what they're talking through on the final rule that goes in effect for January 1st. And it's really not even new rules. It was clarification and really, I would say, a warning for people to get their act together. Is they were huge on accessibility. Make sure that people can access your files. So you can't have it gated, meaning that you have to require personally identifiable information or a login. There can't be a CAPTCHA. different things that you have to be able to access the information, whether it's a machine readable file or your shoppable services file or estimation tool. The machine readable file itself should be a single downloadable file. Now, if you have different files by locations, because you have different fee schedules, different amounts, that's different. But for example, I had one hospital that I logged in and there was a different file for outpatient, inpatient, physician. It was just that should all be in a single downloadable file. You can have separate tabs, but it needs to be in a single downloadable file. As also another thing for avoiding a warning letter is if you look at the verbiage that CMS uses as far as how they're identifying the standard charges, whether it's your gross charge, your payer negotiated charge, your minimum charge, maximum charge, try to align your column headers in the same way that they identify them and use the same verbiage. So you think about it from an auditor standpoint, it's easier just to open the file and say, check, 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 they have that information, and being able to provide that. On the shoppable services side, clarification and recommendation was made as far as being able to have a single estimate of out-of-pocket for a patient should they go into either your shoppable services file or the patient estimation tool. They should be able to figure out, for the most part, what their out-of-pocket is, and more so on that tool. CMS does not want to see a range. And I see that a lot with the Maryland hospitals because of our reimbursement system. We really don't know in a single day, right? It could be a range, but they want to see a targeted single amount to the best of your ability. Reiterating that a good faith estimate is not, and a shoppable estimate is not a contract. You can have disclaimers all over that bad boy, all over that tool, all over the website to speak to the Maryland system. I always encourage people, just pick up the phone and call if you want to get a true estimate, because again, things being moved. So that's a lot. Sheldon, I'm going to put the spotlight on you. So understanding all of these different changes, and the NSA and the price transparency really play off of one another too, because especially on the hospital side, as we start to think about good faith estimates or any type of disclosures, we should already have an idea around our pricing and our charges, or at least the process to be able to get to them. How has this affected you guys at Luminous, and what advice can you give to our members today?
Sure. So it forced us to be project managers, that in essence. So basically, when these different initiatives came about, it was how do you approach it from an organizational level. And one thing I could say the Luminous team was very good at was getting the right people involved very early. So like the team that I work with here, IT was involved, the physicians was involved, and we approached it very pragmatically, understanding what the requirements were, broke it down into different subsets to say, all right, you guys approach this, come back to us by X, and basically started meeting, I would say probably once a week until we hit the timeline. When we did run into, I would say, what we would call obstacles, because you're always going to have differences of opinion, right? I read it this way, you read it this way, then we get legal involved. So we're trying to take up too much of legal's time, and they were very responsive to us. So it's not like we had to wait 2 weeks to get a meeting. They'll say, okay, hop on a call, let's get it done. And then we'll just focus our approach and build it. And what we did establish with all of these is really a building block of how to, right? Because it's not necessarily getting it, you don't want to approach this as a new project every time. We want to know what's the math? How do we, when we get a new legislation, what are the steps that we need to take? And that's where I think that we became very efficient at. So now when we see the different legislations, it's like, okay, project team together, how are we going to handle it? What's the time frame? And then we just take it from there.
So if you were to call out, and that's a good point too, because a lot of different hospitals, especially on the hospital side, when we bring up, how are you doing with the NSA, any of the price transparency changes, it's gotten to be less of a conversation, especially around NSA with our CFOs and revenue cycle side. We're starting to hear more, we're having to get legal and compliance involved because we're trying to interpret. And I think that's right. That's some of the frustration with the No Surprises Act, is the interpretation of what is and what is not required, because like I said earlier, it's a moving target.
Yeah, because like even with the NSA, right? And we're talking about you can't balance bill the patient, if the physician is out of network. And then it was kind of like the light came on and we was talking with the attorneys and I was like, well, we're not liable. We don't own the physicians and we're not the one balance billing.
Right.
That's on them. So it's kind of like, oh, we was so worried about, being out of compliance, not even realizing it wasn't our compliance.
Yeah, I think something, pulling in my, just, thinking about when I sat in the hospital side is I would hear the grumblings from the physicians, right, about what was going on in their offices and their reimbursement that we didn't have control over. So I would just say, be prepared for that because especially with the ancillary services and providers. So if we think about the radiologists, the pathologists, on their professional sides, where they are now, if they're out of network for that patient, they're going to be paid that initial qualifying payment amount.
Correct.
And they're either going to have to accept it, negotiate, or move into dispute resolution with them.
Correct.
And
and with the payer, not the patient.
Right, exactly. And I'm still finding even larger ancillary provider groups that are, so privately owned. They're not part of the hospital system. They're not part of the contracts that still haven't wrapped their hands around this. So I'm thinking by, mid-end January, when they start getting some of these EOBs in, they're going to start kicking and screaming, and they may likely, come to your office. And even though you're going to be like, well, what do you want me to do? I help you navigate you through. Here's the website.
Yeah, I have a feeling
right?
they're going to try to use the hospital as leverage to help leverage the payers. And we'll see. We'll see how far that goes. Because from a hospital standpoint, we bear the same burden. So it's very hard for us to be your advocate when we have the same issue.
Right. Exactly. And I think on the self-insured piece of it, because that if somebody's truly self-insured, uninsured, and even in our current, our payment model with the Maryland hospitals, if we need to provide that good faith estimate, I think where some of the hospitals are struggling, regardless of what state you're in, is how do I pull that together? Because it's very prescriptive of what information needs to be there, whether it's CPT code, it's your standard charges, it's a layman's description, is who's driving that detail, who's filling that out, who's gathering it. So for example, if I were to go to your HIM department and say, if somebody's coming through and say, I'm getting this surgery, they didn't apply to CPT codes, is HIM getting involved?
Well, what we were doing here, especially when the facility fee notice came out and they said you can have a range, what we did was, let's look at the average of what other patients were getting, and we'd use that as the best, the patient estimate.
Mm-hmm.
And the reason why we did that was because if we tried to go down the route of actually defining what a patient's care is going to look like in the future, I don't think that would be a winning strategy for us. We'll just play the law of averages, and it's something that you can also defend. Some of the ranges came out kind of wide when we tried to do the range, so it was scaring patients away. Brent has a question. That's hand raised.
Yeah, I was just going to make a comment on this as well. We know one of the complicating factors, and this is one that was intended in the legislation, but is a huge challenge to us, right? Sheldon, is exactly what you're talking about is the Attorney General's, the Health Education Advocacy Unit, they were really determined to make this at the time of scheduling for facility fee disclosure, because they wanted the patient to know, well, if I have an opportunity to go someplace else, I'm narrowing it back down to facility fees. But that was the thing. We have argued time and time again, look, if you just let us, let's take the scheduling phone call. We understand what they're scheduling for. We could have a much more robust process to probably give you a better estimate. We know that's been a challenge, but that's something that we continue to, as we explain the consumer unfriendliness of how that piece is applied, that's something we've been thinking about. So just wanted to make that comment while you're talking about that estimate.
Yeah,
it's interesting. Go ahead, Sheldon.
No, I'm saying we was having that same challenge. When we first put it out there, we had a lot of departments come back and say, you're scaring away our patients. I mean, there's no way they're paying $5,000 or $3,000. And I'm like, yeah. So we had to kind of come up with a logic that was pretty fair. What we realized was that we couldn't do the same logic across the board for everybody because it didn't apply the same to each of those ancillary departments.
Right. It's really, I think it's like you said, bringing together the stakeholders is one piece, but it's also, let's start running through some scenarios, right? And flowing that out and understanding who has to be involved and what that particular impact is, because it really can vary. And I think, not to bash, HHS or any of the other governmental bodies that were involved in pulling this act together, but I think the complicated nature in which we have set up healthcare reimbursement and operations and different things, I don't think they quite get that piece. I mean, if you look at even in the part 2 of the No Surprises Act, there's an example in there about knee replacement surgery. And so they talk about, how they would touch all these different people. There's a stay, there's the surgery, there's anesthesia, there's all of these different pieces, and having to pull all of that estimate together. And they even gave an example provider model spreadsheet. Like, oh, that looks really easy, but that's not that simple to be able to put that together. And then one of the things that's baked in, just as a warning, on the uninsured piece, is that if your charges end up in excess of your estimate, that an uninsured patient can go into their own dispute resolution process. That amount is a threshold of $400. How easy it would be to hit add an additional $400 to somebody's estimate. I mean, that's low.
Correct.
Right.
And I think when you brought up the fact about the different CPT codes and how we charge, I mean, one of the things that was brought up at, I would say, Becker's, was that I brought up the idea of, if the government wanted to try price transparency, why don't we have a standardized charge master nationwide?
I would love to help create that, because I have said the same
I'm like,
thing
that
for
would be the
years.
first step, right? I mean, we don't all have to have the same price, but at least now we're all talking the same language.
Well, and I always, because, and Lauren and I, we work outside of Maryland as well. And I always brag about the Maryland system, because at least we have a standardized method for capturing charges, right? Where you go outside of Maryland, we don't necessarily have that. So if we pick like on interventional radiology, we're by minutes, where we might have procedure based in one hospital, or they could be by minute, they could be by 15 minutes, they could be all over the place. How things are calculated is just not the same, but there's definitely some opportunity. And I know for our panel, our facilitators, some of us, or many of us, we're 20 plus years in, right? So we've seen the evolution of fee schedules to, composite rates, to how things have gotten more complicated and, fancy in our reimbursement structure. The operational piece is kind of fallen, a little bit slower behind that. And now we have these regulations coming in that, to me, would have been much easier 20 years ago to implement, because we weren't as complicated. Because now we have the technology involved, the different processes, all the regulatory pieces have gotten complicated. It's not an easy task. So I did have a question about the NSA applying to urgent care and ASC. So if you look at the NSA, as far as the good faith estimate that's going to be required January 1st for your self-pay uninsured, yes, that's everybody. Just put that into everybody. As far as the NSA related to notice and disclosure, if there is, the good faith estimate is not required for your out-of-network insured patients under the NSA as of yet. But as far as that qualifying payment amount, the initial payment, the opportunity to negotiate for our ancillary providers, that piece, I'll go through the list again. It's hospitals, hospital outpatient departments, emergency rooms, freestanding emergency, ASCs, and urgent care centers that are licensed in the state to provide emergency services. And I honestly don't know if Maryland has that. I don't know, Brett, if you would know that, if they look at urgent care centers and license them to provide emergency services or not. I don't believe so. I think that's a state by state.
Yeah, the urgent care centers, at least in Maryland, are essentially, licensed as physicians' offices. We have several freestanding emergency department facilities that are licensed as, we call them freestanding medical facilities here in Maryland. So, we have several of those, but from an urgent care perspective, not licensed to provide emergency services here in Maryland.
Okay. So if you're take the hospital piece out of it, if I'm out of network, So what the NSA is going to do, for example, for our urgent care centers, or I'll say for, let's say we have freestanding emergency room and I am out of network going to that emergency, if that's considered an emergency under layperson law. So there's a difference. There's a lot more under the NSA that we're not even touching on. But let's say that I'm out of network, what's going to happen is because I'm out of network and I'm deeming that an emergency, they cannot provide me notice and disclosure necessarily around that piece and tell me to go elsewhere. What's going to end up happening, and this is where some of the emergency physicians are raising their, not so happy about this piece of it, is that now they're waiting for that initial payment to come in from the payer, and the payer, how they come up with that qualifying payment amount is 3 different ways. So it's either if you have an all-payer model, which that's what's going to apply for our Maryland hospitals, or if you have a state requirement and methodology of how that's calculated, which many of them are in the process of creating and may not have. Well, most of them are going to take it to the third option, where the payer now is in control of looking at the in-network the median in-network rate for that type of service in your geography, providing that information back to you and saying, this is what I think you should be paid. You have 30 days to provide, have an open negotiation period. And then if you can't settle that, then now you're going into independent dispute resolution. That's a lot of time, administrative costs, and just a pain in the butt to have to do. So we're advising, especially our ancillary providers, emergency providers, on the physician side, where they can negotiate with payers. If they can identify a certain payer that they see a fair amount of frequency of, that they may know that they intentionally have not contracted with before, may want to revisit those conversations before January 1, because otherwise you're going to end up negotiating in a different way. So I know we're a couple minutes over our agenda time. Now, if there's any other questions, this is the topic that as we go into our breakout rooms, we can talk about. Additionally, if there's any tips, tricks, questions that you have on operations, implementation, you'll be able to share that amongst your peers. And again, if you have any technical questions for any of the topics today, you can send those in chat. You can reach out to our facilitators and we'll try to get back to you. And to keep along with our agenda, I'm now going to turn it over to Lauren to talk about CDM and PAMA.
Thank you, Caroline. Great discussion with all of you. I was nodding my head along to most of it. So really appreciate that. And just want to again encourage folks to type your questions in. But we are going to move as quickly as we can into breakout rooms, because as Caroline mentioned, that was always the best part about this event, was being able to talk to your peers. And it's been so challenging with the pandemic. So just some quick updates this year relating to CDM and something about the lab fee schedule as well. So regarding new codes that have been added for January 1, don't forget that every rate center has by report criteria that explains how to develop those RVUs for HSCRC purposes. Sometimes it can still be challenging. If you're having issues, reach out, try and get clarification, because the HSCRC does look at those by report RVUs. If you don't already have one, create a by report log to track any code where you've created an RVU and how you did that, in case it's called into question. Looking at the new ads this year, so there are, of course, new lab codes. And remember, for that rate center, if you can find a test similar, great. If not, you might have to dig a little deeper, look into the cost of that test compared to your lab rate. Also, I want to mention, and this is not just a lab issue. I was corresponding with someone yesterday, which reminded me of that. Remember that any service associated with COVID, so that can be lab tests, the vaccine administration services, Maryland is supposed to keep in line with Medicare pricing, which is also a moving target. So, keep an eye on that. Dennis does release memos letting folks know about new codes and new prices. And Novitas actually has some really good resources, links on their page that have all the prices together. So that's something to keep an eye on. Remember, your RVUs would be normal RVUs or the RVUs that were provided by Dennis's prior memos. But the rate is supposed to mirror Medicare. And that'll probably be the case through until the PHE ends. Imaging, there were some new codes, and normally it would be simple and you could go to the Medicare physician fee schedule and pull those RVUs. But I was hearing from folks this week that some of these new technology codes that your imaging departments might be doing, they don't have RVUs because they're carrier priced. So I know we're looking into that a little bit to come up with maybe some recommendations, but you might need to do some digging into that. The best laid plans, you know how that works. But some of them will be in the fee schedule and you'll want to use those RVUs. There's also some new EKG codes, new pulmonary rehab codes this year. If you look at those rate centers, you'll notice that they were supposed to kind of be based on minutes and time. So if you can find a similar service or talk to your clinicians and learn how long these services take. Pulmonary rehab, remember, can be a little tricky because that's in a group setting. So something to keep in mind there. And then we'd love to hear from people on as patient monitoring grows and how that relates to Maryland, because that's tricky. That's where the patient is at home and we're seeing this sort of explosion in RPM and the way the HSCRC works, you know, if that patient didn't come on site. So that looking at those codes, you'll want to be very careful how you're structuring those. It can just be challenging juggling national versus state guidelines. Just wanted to remind folks, we do have an RVU conversion coming up. It will be, unless something changes, it will be July 1st. And a group has been meeting for quite some time now. Clinic is not only a large rate center, but it has a lot of tentacles into other issues, pro-fee billing, all kinds of fun topics. If you haven't been attending those meetings, you probably want to make sure at least someone from your organization has been attending. Jennifer Gardner from University of Maryland is doing an amazing job of chairing that group. So if you want to be included, it is meant to be all inclusive, no surprises. And again, the conversion is supposed to be July 1st, and we'd love to have you in those meetings. And then one more item, PAMA and the clinical lab fee schedule reporting, been getting some questions on whether this applies to Maryland. This reporting is due, I believe, March 31st. It's been postponed multiple times. It doesn't specifically say that Maryland is excluded, but there is a calculation that they provide, or they have a whole website dedicated to this on cms.gov. And there's a calculation that you have to prepare. I am thinking it wouldn't be likely that a lot of hospitals have to report this information. Again, it doesn't say Maryland's excluded and hospital labs are definitely included, but because Maryland is paid differently, you might not have to report. But just remember, there are services in Maryland, unregulated lab, that is paid by the fee schedule. And their intent was to be inclusive this time. When they first did all of this reporting, it was basically like LabCorp and Quest submitting information. And they wanted to move away from that and make sure that everyone had an opportunity to share what their fees were. So something to keep an eye on. Again, it might not apply to you, but we just wanted to mention it because it's definitely been causing a little confusion with Maryland hospitals. Those were the main updates that I know I wanted to cover. I just wanted to echo some things Caroline said at the beginning. You know, when these meetings started happening, and Brett, I actually remember, because this was quite a few years ago when we talked about, you know, how can we have this sort of open forum? And you had said, well, you can use space at the MHA, and why don't we run it through Maryland HFMA? And, you know, this event just has grown each year. And so again, it's been a little bit of a struggle with the pandemic to keep it interactive, which is what it was always meant to be. But I hope everyone kind of likes the format we're using this year, where, you know, we have a little bit of high level discussion in the beginning and then allow folks to go into the breakout rooms. My only concern, and we were discussing this, so because we're all in individual breakout rooms, we're not all going to be able to hear the same discussions. And we did try to align breakout rooms as best we could. But again, when we were in person, you weren't limited to your own table. You could go over to other tables and talk to people. So with the type A in me, would love if you were in a breakout room and could possibly maybe jot down ideas, notes, things that are shared, and provide them back to Caroline, either through LinkedIn, or her email address is actually on the next slide. We would love that, because we could disseminate all that information to all the attendees today. Again, I know you're probably groaning. Did she just tell me to take notes? But again, we're hoping that by doing that, we can kind of share information globally with everyone until we can be back in person. And hopefully, Brett, when that day comes, we can use that big room again. But we just want to thank everyone for joining. As Caroline mentioned in the beginning, you're going to get a pop-up that will tell you to go into your breakout room. So if you can just accept that. And also, when the breakout room discussion ends, the event is actually not over. So if you can come back into as a large group, we just have some closing announcements. It'll only take a couple minutes, but we just want to make sure everybody does that. Okay, so with that, I'm gonna go ahead and move to the next slide to show Caroline's information.
There it is.
There's the spelling of Caroline's last name,
That
which I
long
realize
email.
I'm mispronouncing, and I've known you for most of our lives. Sorry about that. And here's the topics. Some conversation starters for the breakout rooms. Don't let this limit your discussion, but we also don't want these rooms to have crickets and people not talking. So with that, see you guys when we come back together.
All right, great. So I think we're waiting for our pop-ups. Is that it, Kalita?
Yes, it's
Okay.
there. However, it looks like Zoom failed. So give a second while we go ahead and manually put some of you guys in the room. But if you know your health system, you can actually go ahead and join the 4 rooms. It's Cerner, Epic, Meditech, and other. In the interim, we're going to go ahead as a Zoom committee and push you guys in the rooms that were assigned. Okay. So bear with us. Thank you.
No problem. Thanks, Kalita. Okay, welcome back, everyone. Want to apologize. I know there were some technical challenges with the breakout rooms. So thank you for bearing with us. I was in the Cerner breakout room. We were able to have some good discussions, but I know there were some issues experienced elsewhere. We were the guinea pigs. Caroline, we're always the guinea pigs. You were the networking guinea pig last year. But just some closing remarks before we wrap up today's event. First of all, a huge thank you for all of you that chose to join. We know how crazy your calendars are, so we really appreciate you joining. Evaluations and CPEs will come out, should be automatically from the CVent system once we update our participants in the system. So it is important that we know you were here. If you put your name in when you logged into Zoom, you should be fine. We'll know it was you. We'll be able to see your email address. But if there's any confusion there, again, we need to make sure we get logged you as a participant so you can receive the evaluation in the CPE. If you need the CEUs, Caroline provided information on how to contact her so you can get those AAPC CEUs. And just to let everyone know, January is always the month where we have an HSCRC workshop. Timing, format, all of that is being developed. We're trying to meet the needs of all of our members during a pandemic. So please keep an eye on the Monday mailer for updates on that and how to register. We know that's the biggest event of the year. So hope everyone can join. And with that, just have a great rest of your Friday and a wonderful weekend. And thanks again for joining us.